And thanks everybody for their statement today. Just my first question is in relation to the pharmacy force model in Scotland. When was that implemented?
So the origin of that really was back in 2006. They had a minor ailment scheme, and then it became a little broader in 2020. So it's just in 2020, and it's that real symptoms focus. It's more like a triage model, I guess.
Okay.
Patient come in, you get the assessment of symptoms, advice, referral, or treatment.
Okay. And in that situation, can pharmacists then prescribe certain medications?
Yes.
In that environment?
Yeah, so in the Scottish model, they use a structure called patient group directions to supply the prescription-only products, and that's to a certain cohort of patients if they fulfil certain criteria. So, for example, they can give acyclovir to treat shingles, they can give fusidic acid to treat impetigo. So there's a number of different specific conditions that are prescription-only medicines but are supplied by the pharmacist on foot with structured consultation.
Okay. And is there any circumstances in Ireland at the moment that if somebody, just say, is there any medications you can prescribe?
So at the minute, we talked about Schedule 8 of the Medicinal Products Control Supply Regulations, and that is where there are certain prescription-only products that you can supply and/or administer. So that's how pharmacists deliver flu, pneumococcal, shingles, COVID vaccines, but also administer certain emergency medications. So naloxone if somebody has an overdose, if there was glucagon if somebody was having a diabetic crisis, there's also salbutamol if somebody's having an asthma attack. So it's medicines in an emergency situation. Pharmacists can and do administer adrenaline if somebody's having an anaphylactic reaction. So you've got that immediate kind of urgent emergency care currently being delivered in the pharmacy setting through that structure.
Okay, so if somebody presents themselves in that situation, you can administrate that medication?
Can and do, yeah.
Okay, that's interesting, yeah. And obviously the minor ailment scheme sounds a brilliant idea. You know, obviously other jurisdictions have implemented it, and it kind of seems to be a bit of a no-brainer. Has there been any kind of resistance from, I suppose, GPs in relation to the possible implementation of such a service?
Well, I mean, pharmacists and GPs work very closely together in primary care, and they have a very good, strong working relationship on a local basis. So if the idea here is the patient, and I think you've got two healthcare professionals who put their patient first, and if the patient can be dealt with at the lowest level of complexity, be that in the pharmacy, I think GPs can be supportive of that and have been. So we will often refer patients to GP. Equally, GPs will sometimes refer patients to pharmacy. So I think being able to work together and put the patient as your kind of core element, and if pharmacists are, I think, embedded more into primary care networks, that will become even stronger in terms of that interdisciplinary working in that primary care setting. Okay.
In regards to 1 million appointments, where would you get that figure from?
So we looked.
This is not criticism, I think it's a great idea. It's great.
So there was work done back in 2016, 2017, and we can share that report. I don't have the exact detail of all the figures there in terms of how it was worked through, but we can certainly submit that if necessary. But we looked at the number of the types of conditions that were being treated in the GP setting, and the types of medications that we know can be utilised to treat minor ailments. And we can look at the dispensing data in the state, and we can say, well, actually, this is the number of incidents of those particular types of illnesses that are being treated in the GP setting. So actually, if we take that out of their workload, you could free up 1 million consultations. We worked it out to be something like 100 full-time equivalent hours worth of capacity within that sector just by introducing a service such as this.
And what would the classic example of that be?
Of a minor ailment?
Yeah, no, say a person going to the GP, and that you know, their interaction ending and coming to pharmacists in relation to the minor ailments. What would the classical, I suppose, presentation be? If there is a classical presentation? Well,
there's a range of different conditions. So we've estimated there's something like in Wales they treat 26 conditions, so there's quite a number. But if we take the example we took earlier, like uncomplicated athlete's foot, there's a cream that you can get over the counter. You can come into the pharmacist can assess your symptoms, say, I know you need that medication. Unfortunately, I can't give it to you because I cannot provide a prescription. I can't provide this item free of charge.
Even though it's right beside them?
Oh, it's beside us on the counter, so we could reach back and pick it up, but we can't because they need the piece of paper that says the doctor has written the prescription, therefore it's approved on the medical card, therefore the pharmacist can supply it. So you can imagine the time and effort it's taken for the patient to have to go off.
It seems ludicrous. It just seems ludicrous, doesn't it?
Yes, we would agree.
Why have they not changed it?
That is a question, I think, for the department, but we hope that they'll think about it and maybe agree that this is something to do.
Something as rudimentary as something like that.
Yeah.
It sounds like it's a ridiculous situation where somebody has to go to a GP.
When we talk about care at the lowest level of complexity at all times, this is a clear example of that. If it's not complex, pharmacists can safely deal with it. They should be enabled and facilitated to do so.
There must be resistance somewhere. I mean, obviously, this comes from probably different vested interests as such.
I don't know. I think change can be difficult. Dermot might speak from a...
Yeah, so again, as we mentioned earlier, it's about, I suppose, thinking outside the box. It's about being agile. It's about looking at being disruptive. Ultimately, as Susan and my colleagues have said, it's about patient care. Ultimately, it's about lack of planning. But in fairness to the Minister at the meeting, he certainly seemed to be very keen to move forward on some of these proposals. But, colleagues who've been president of the IPU before me, Cathy was one a number of years ago, I've heard similar words and platitudes. Really, it's about action at this stage. In terms of the minor ailment, just to give you a little bit more context, it's about equity of access. So a person, if they have money in their pocket and they're able to get this particular product, then they can source the product and get it in the pharmacy. Whereas the person with the medical card, they have to recourse back to the GP. So that's an inequitable system. But equally, as Susan has mentioned, it's about expanding the scope of practice. So there are a number of other conditions that the products would be prescription only currently, and it's about thinking big and moving on some of those, as your colleagues have said, working under protocols. And very often there may be scenarios where we won't be supplying a product. So, for example, as the other deputy mentioned, emergency contraception, we would often do consultations in that where a product supply is not suitable and it'll be referred to the GP. We would see that may still be the case with regard to minor ailments.
The morning after pill, you don't need a prescription for it, do you? No, you just, okay. And just my final question is in relation to contraception. It kind of, again, it's kind of ludicrous that, the interaction, you would need a prescription. Is there any other states in Europe that is happening, that you'd actually need a prescription for, again, a rudimentary medicine such as contraception?
Thanks, Deputy. Yes, there are some states in Europe where you do need a prescription still for contraception, but there are just as many where it's available without prescription as well. We, as Dermot has said, we want to be proactive.
Do you know which countries has this kind of still...
prescription-only medicine?
Yeah.
I'd need to be sure. I can get that information to you. But even our nearest neighbours, the UK moved in July 2021 to move progesterone-only contraceptives to pharmacy supplied. Yeah.
Okay.
Yeah.
Okay. It'd be just interesting to see what countries still have this policy in relation to. It may be the kind of historical. I'm careful how I say this, but there might be. There may. Yeah. Okay, I think I'm running out of time. Thanks very much. Just my final question is just in relation to the drug Caraban. I don't know if you're aware of this drug, and I know some people have contacted us in relation to this issue, and it seems very convoluted that such a drug that has it's very kind of effective in relation to acute nausea, that women have to go via. Hopefully, correct me if I'm wrong in this one. They have to go to their consultant. Then they get the prescription via the consultant. They go to the GP. They get it via the GP, but they're not reimbursed immediately. So obviously, it's making accessibility very, very much more difficult than it should be. And I know the Minister has put funding in relation to the accessibility of Caraban, but it seems a very kind of arduous process in relation to women getting this very, very vital drug. So I don't know if you'd like to comment on that.
Yeah, I think we would agree with you. It's great that there's funding put forward, but actually there's structures then in place with the PCRS, the HSE, in terms of how that actually works in practice. So often when they bring new medicines to the market in terms of funding them, they will put some specific restrictions on the supply of that, and that's to control spend in often cases. With Caraban, the structures they put in place is, yes, you're right, you have to go to a consultant in the first instance. So the very first prescribing of Caraban needs to be consultant initiated. After that, the patient can go to the GP, and their second and third and subsequent prescriptions can be GP initiated if necessary. So once the initial approval is in place, then the GP can kind of follow on with that prescribing. Now, the patient can come from the hospital with the consultant approval to the pharmacy if they're a private patient. If they're a medical card patient, you have to do that step where you go to the GP, get it written on the medical card prescription, and then come to the pharmacy. So there's lots of barriers along the way. So there's lots of places where there's a barrier to access. So I guess what we would say is we welcome the funding for Caravan, but we think the system's in place to actually realistically have it approved in practice and women actually accessing it put too many restrictions in place and just delay the access for those women.
And the Caravan is a non-licensed medicine, is it? Or it's a licensed?
So if you talk about unlicensed, it is licensed in another country. It's just not licensed in Ireland.
For acute nausea?
Yeah, so it's safe and effective, but it just doesn't have the licence in Ireland because the company have decided not to apply for that licence and place it on the market.
And I presume if it was licensed, then there wouldn't be this issue. Am I correct on that?
Well, I don't think you can say that. So it all depends on the HSE. So the HSE are the ones who make the decisions around how medicines are accessed. So we have plenty of licensed medicines in Ireland that have similar type of restrictions in order to control access, funding, make use of the drugs budget. But those are the kind of things when we talk about administrative burden in pharmacy, all of those different systems, dispensing a prescription isn't quite as simple as it used to be. And a lot of your time and attention is focused on the administrative, am I going to get paid for this? Where it should be focused on the clinical, is it safe for this patient? Does it interact with their other medications? That kind of thing.
Thanks very much.